Good afternoon and warm welcome to this webinar. This is webinar number 13, I think, in the series of webinars organized by the GHD EFNet in response to COVID-19. Today's webinar is on increasing vaccine demand and uptake during the COVID-19 vaccine infodemic. So many thanks to the GHD EFNet team. My name is Hiam Bashour. I'm an academician and public health expert from Syria. Very pleased to facilitate this webinar with my co-facilitator, Mr. Atsu Ishizumi. Atsu is a fellow on the demand for immunization team at U.S. Center for Disease Control and Prevention. He has been involved in a number of research and implementation projects for improving vaccine confidence and demand globally. Currently, he is supporting an epidemic management project in Indonesia, coordinating behavioral assessment and intervention development in collaboration with in-country partners. Well, it's now over a year when WHO, the World Health Organization, announced COVID-19 as a global pandemic. Globally, as of yesterday, 29th of March 2021, there have been over 126 million confirmed cases of COVID-19, with over 2.7 million deaths reported to WHO. Another epidemic of information and misinformation related to coronavirus, the COVID-19 disease, as well as COVID-19 vaccine, have been very much worrisome in the last year or so as well. The term infodemic has been widely used by WHO and other health agencies. Merriam-Webster defines infodemic as a blend of information and epidemic that typically refers to a rapid and far-reaching spread of both accurate and inaccurate information about something such as a disease. As facts, rumors, and fears mix and disperse, it becomes difficult to learn essential information about an issue. The issue, actually, we are concerned about in this webinar is the COVID-19 vaccination. Worthy to say that as of 25th of March 2021, a total of 462 million and over actually vaccine doses has been administered. Unfortunately, the distribution of those doses seems very much unequal. According to WHO, an infodemic causes confusion and risk-taking behavior that can harm health. It also leads to mistrust in health authorities and undermine the public health response. An infodemic can intensify or lengthen outbreaks when people are unsure about what they need to do to protect their health and the health of people around them. With the growing digitization and expansion of social media and internet use, information can spread more rapidly. This can help to more quickly fill information voids and can also amplify harmful messages, including rumors. Infodemic management, according to WHO as well, is the systematic use of risk and evidence-based analysis and approaches to manage the infodemic and reduce its impact on health behavior during health emergencies. Having set the scene, I'm very pleased to introduce this webinar with three distinguished speakers. The webinar aims to bring experts together to exchange knowledge, best practices, and lessons learned from global and regional infodemic trends and approaches, to share a real country experience in tackling COVID-19 infodemic and discuss what have been seen or try to address misinformation, to discuss and propose actionable approaches and strategies to address the COVID-19 infodemic and misinformation, and finally, to discuss building resilience against misinformation in health system and the public using different resources. We have with us, in the order that they will present, Dr. Abdel Halim Abdullah, the Crisis Communication Officer for the WHO Regional Office for Africa, and Dr. Nayaz Muhammad, the Director General Health Services in Khyber Pakhtunkhwa, Pakistan, and last but not least, Dr. Sadomar, the Director of Yale Institute for Global Health in US. The first speaker is Dr. Abdel Halim Abdullah, who will present on the emergence of the COVID-19 infodemic and its effect on vaccine demand and uptake. Dr. Abdel Halim Abdullah is the Crisis Communication Officer for the World Health Organization Regional Office for Africa. Dr. Halim is the coordinator for the Africa Infodemic Response Alliance, AIRA, and its social media arm, Viral Facts Africa. He is also the co-chair of the Risk Communication and Infodemic pillar of the World Health Organization COVID-19 Vaccine Demand and Readiness Task Force. Abbreviation is ACRED. I think we'll hear from you, Dr. Abdel Halim. Dr. Abdel Halim will present for 15 minutes, and then Mr. Adzu will kindly moderate the Q&A for Dr. Abdel Halim for another 5 minutes, and will kindly introduce the second speaker. May I kindly remind the participant, and thank you for all the attendees in this webinar, may I kindly remind you to post your question to the presenter in the Q&A window, naming whom the question is for, and kindly use the chat box for the other general comments. So may I kindly ask Dr. Abdel Halim to share the screen, and we look forward to your presentation. Thank you so much.
Thank you so much, Dr. Ham, and thank you so much for the invitation. It's a real honor and a pleasure to be here today. So I would like to share my screen and give you an overview about the work that the infodemic, as to start with, is definitely not, I mean, misinformation in general is not an issue that just started with COVID-19, with the pandemic, but on the contrary, it's something that is as old as time. And the clear issue that we're dealing with here, this is the first pandemic that we're dealing with time of social media and the hyperconnectivity of the world. So the impact of social media and different platforms and the whole concept of the community today has changed significantly with the situation that we're dealing with today. In our region, I'm going to give a quick overview about the work that we're doing on a regional level with the WHO Africa Infodemic Response Alliance. So this is a network that has started to counter health misinformation and information gaps in our region. And this is a collaboration between a number of partners. We have UNICEF, IFRC, Africa CDC, Gavi, the Vaccine Alliance, UNESCO, UN Verified, and WHO. In terms of participating entities, we have, this is a collaboration where we're trying to bring the different health organizations, as well as with the different organizations that are debunking misinformation. These are fact-checking organizations that are part of the international, the IFCN, or fact-checking network, International Fact-Checking Network. These are Africa Check, AFP Fact Check, Dubawa, PESA Check, Ghana Fact. These are the biggest fact-checking organizations in our region. The goal of the alliance that we have is related to responding to the infodemic in a timely manner and boosting infodemic research. There's a lot of things that we don't know about the infodemic. We would like to strengthen the resilience of citizens against misinformation and disinformation, empowering media partners to professionally and effectively share life-saving information and debunk disinformation on health issues, and encouraging proactive disclosure by data holders. The work that we're doing is all focused on the infodemic management framework that WHO at a global level back in April has developed with 1,300 academics, researchers, practitioners, and experts in misinformation management, as well as the tech companies and private sector. And this infodemic management framework is divided into 4 main pillars. So that's identify, simplify, amplify, and quantify. Identify the misinformation and the information gaps, simplifying the knowledge and the technical knowledge and the correct information, amplifying it strategically through the different mediums and channels, and quantifying the impact of these interventions. So the work that to kind of make this in an operational manner, the work that we've done here mainly focuses on 5 different areas of work. So we do coordination to make sure that all the different partners, because this is a big partnership, all the different partners are aligned and working together. Advocacy to make sure that the work that misinformation management and infodemic management is high up on the agenda of the different ministries of health, and as part of the response for starting with the COVID-19 response. Research, again, is trying to better understand the research, better understand the state of the infodemic in our region and the work that is being done and how effective is it, and these different responses, and also trying to quantify and understand different metrics around to assess the impact of the infodemic on people's behaviors and on the work that's being done on a country and on a community level. Then country support, that's a tailored response and focus for each country. We're trying to highlight priority countries that have high internet penetration and are considered media hubs to be able to respond to that. And finally, there is this Viral Facts Africa, and this is an initiative that we are launching actually today in parallel to this session. So the idea of building Viral Facts Africa was the fact that we realized that the majority of the misinformation that is spilling over from one country to the other, again, the uniqueness of this issue is related to social media. That doesn't undermine the importance of traditional media nor the community-led initiatives to debunk misinformation and to correct misconceptions and rumors. On the contrary, but this is something that we know that there is a big gap in kind of the narrative and the discourse online. So we're trying to make sure that the misinformation that is highly visual, highly emotive, that is spreading all over the place is a bit more controlled that it has some sort of competition, and that's what we're trying to do with such content, is that we are trying to repackage the work that we're doing to be able to compete with this kind of misinformation in a visual, engaging, and a shareable manner across the different platforms. We would like to, we've done pre-launch. We have produced about 50 videos starting from February, and in both English and French. These are the language, English, French, and Portuguese. These are the main UN in the region. But we've mainly focused on English and French. And the content that we have produced has reached more than 20 million views and more than 500,000 engagements. The content that we have developed through Viral Facts has been mainly focused around having these templates or the canvas that we would be able to kind of, in a timely manner, produce content and make sure that it's available, readily available, easily translated to different. This is one example for one piece of content that we have produced in December last year. And it had actually, it's the most viewed fact check in the region. And the reason why we're saying that is that fact-checking organizations, they produce a lot of content that is kind of all over the place in terms of they produce a lot of content, but it's mostly not really shareable because it's produced in a story format, in an investigation kind of format, which is really not the most efficient way to compete with a piece of, with one all over the internet and social channels. So we produce this content on a myth, debunking a popular myth, which is that hot weather doesn't really, that hot weather limits the transmission of COVID-19, or that COVID-19 in hot areas. And this has really resonated with the audience. So on vaccines, the work that we're doing is really, I mean, in terms of crisis communications, and the work is really important because we're trying to leverage the WHO and the different partners to be able to push forward the correct messaging and make sure that we are pushing the work that we're doing across the different languages, etc. We're producing explainers, mythbusters, debunks of around COVID-19 and the COVID-19 vaccines. And I apologize for my messaging is, my team is going crazy. We have produced a number of material, as I said, and we're trying to co-brand the work that we're doing with WHO branding, UNICEF, Africa CDC, and these are the key, trusted sources of information that we have. We started actually the first viral facts video with a video on polio because we had announced the eradication of wild polio virus last year in August 25th. So there was a lot of misinformation because polio is not entirely off the map and off the radar, but on the contrary, there's still cases of circulating vaccine-derived poliovirus. So there was a lot of confusion, and we anticipated that. We tried to get ahead of the misinformation to make sure that it doesn't affect vaccine uptake. And there was a lot of cases, a number of cases, not a lot of cases, where people were skeptical about the polio vaccine, and they thought that it was COVID-19 clinical vaccine being tested on them and on their children. So there was a lot of misconceptions around that. We had to, in order to be ahead of the misinformation, we tried our best to brief, to give a good brief to the fact-checking organizations, to local media partners, to be able to get ahead of this. When it comes to misinformation debunking, there's a lot of, around vaccines especially, there's a lot of there is a lot of skepticism about the impact of debunking misinformation vis-a-vis producing correct information. And UNICEF actually, they've done their homework on this, and they have produced the fact warning fallacy fact kind of format to kind of debunk misinformation. And to the left here, you can see the template that is designed specifically to debunk misinformation around vaccines under that format. And to the right, you will see the one product that we've done. And again, we are here referencing the UNICEF vaccine misinformation management field guide that actually has done the research around this. This is a snapshot about the work that we're doing for Viral Facts since we started pre-launch. As you can see, the numbers are on the rise, and we're almost at 3 million views for our videos. Half of our content is around vaccines because that's the majority of the content that we're producing. I mean, that's the majority of the discourse actually around COVID-19 in the region is mainly around vaccines. And these are just the numbers from starting from February, and the 20 million figure that I mentioned earlier was including the products that we have tested last year. But last year we had sporadic products, but this year we have started producing steadily and starting from February. The kind of collective reach of the partners is focused. the collective reach of the partners on social media is about 10 million, 10.5 million followers on social media, which is huge. But at the same time, we're trying to make sure that this content is leveraged through all of their networks. So it's instead of just WHO posting to their 1 million followers, it's WHO, UNICEF, and they're all sharing the same message with different branding. We created this new brand to make sure that it's co-owned by all the different partners and the fact checkers and the media outlets out there, to have a clearance house for producing content, factual content about COVID-19 and about health information in general. So these are different formats. As you can see, this format with the WhatsApp messages kind of simulation is actually very popular, and it received a lot of engagement. One of the things that we hope that we would do is that we would engage with more people across different channels later on, not just through social media. This is just one tiny example. I know I'm out of time, but this small tiny example about the AstraZeneca suspension, and just the fact that we produced content that was timely, really filled a big information gap, kind of work of misinformation actors on that. This is one of our spokespeople addressing the side effects question in the blood clots. One last point is just about content testing. We try as much as possible to use to test the message efficacy and the content formats and the shareability of the content that we're producing. We're collaborating with the University of Stanford, we're collaborating with Facebook, and we are also building a network of super spreaders for viral facts super spreaders who would be able to kind of share the work that we're doing. These are healthcare workers, frontline workers, journalists, celebrities, community leaders, academics, students, to share and amplify the work that we're doing. They can also be more involved with co-designing the work that we're doing, giving feedback, and stopping viral rumors and sharing viral facts. I will stop here and happy to answer any questions.
Thank you, Halim. That was great. I think it's great to always hear from people really working on the ground to address the infodemic. And I think what IRA, or Africa Infodemic Response Alliance, is doing is really at the forefront of infodemic management. So it was a great summary of your great work. Thanks. So I think we have a couple of questions from the audience. So the first question is, what are the major challenges you are currently facing in managing the COVID-19 infodemic in general and vaccine uptake in particular? So what are some of the challenges that you're seeing with your work, in your work with IRA?
Yeah, absolutely. I think there's a lot of challenges. One thing that we are facing when it comes to the nature of the infodemic is that, again, as we mentioned, it's like a disease, like doesn't care for borders and crosses borders and all of this. But so when we see, for example, anti-vaccine content or anti-vax content coming out from the US or from Europe or anywhere in the global north, even in France, in Francophone Africa, it definitely impact the discourse and the narrative that we have. One of the things that we try to do is to make sure that we anticipate things that will go viral in the region, as I mentioned, by monitoring also the broader discourse, the anti-vax discourse on a global level. And we try as much as possible to get ahead of for the region. So once it hits, we are ready with corrections, material, talking points, and all of that. Another thing is in terms of challenges around working with on infodemic management is basically quantifying the impact. Okay, before working on the impact, but quantifying the volume of misinformation that is actually circulating and its reach. I mean, we can monitor through different social media listening tools and media monitoring tools. We can monitor the discourse. We can keep an eye on it on a qualitative level through qualitative analysis. But when it comes to quantitatively kind of better understanding, so how bad is it, or what is the impact on this, it's a bit difficult to do it. we're trying to develop, one of the things that we're trying to get around this is to better understand the share of voice of trusted sources. So making a list of trusted sources and, correct, the trusted institutions, media outlets, all of that, and the key allies in terms of religious and traditional leaders, the healthcare workers, etc. And then measuring the reach of their messaging and the things that they're posting vis-a-vis the broader discourse and the broader conversation around COVID-19. So that's just one of the things, but there's a lot of questions that we still don't know fully, and there's a lot of challenges with influence operations and disinformation, where you have certain actors, whether state actors or non-state actors, who are actually pushing for a certain direction. So these are just like quick, broad highlights.
Great, thanks. Maybe, I know, Halim, you have to go soon, but maybe a couple of more questions. In your infodemic management work, are you digging deep to understand motivations behind these infodemics? If so, does this affect infodemic management, and how?
Yeah, absolutely. I think one of the key issues is that there's a lack of research on the topic, and that's one of the things that we're trying to tackle with IRA. We are collaborating with a number of research institutions and universities in the region to try and tackle that. For the moment, there is still no comprehensive study to do it, but we are working towards having a report, hopefully before the end of the year, that would document the state of the infodemic. That's definitely one of the key research questions that we would like to tackle.
Great, thanks. So maybe one last question. What are the challenges in dealing with demand while supply is low, or in some countries, vaccine is still not available?
It's a very important question, because in our region, we are trying to, there are priority groups, and we are trying to make sure that these priority groups firstly are pre-listed, and that they have signed up to get the vaccine, so it would be easy to deploy. But then and then we would focus on that. We haven't engaged in massive demand generation activities on public communications in the region around this, mainly very targeted on those priority groups. Even our call to action is mainly focusing on those priority groups. The kind of vaccine hesitancy and around by those priority groups, who are mostly healthcare workers, definitely impacts the broader discourse around COVID-19 and the COVID-19 vaccines per country. And even one country suspending activities vis-a-vis the others, it's also very different. It does definitely kind of a narrative and the sentiment around this. But when it comes to vaccine demand generation, again, we're trying to balance between making our objective at the moment, communications objectives at the moment, is to make sure that we create a more positive or neutral discourse around COVID-19 vaccines, reiterating the fact that they are safe, reiterating the fact that they are effective. Every day there are changes. We've seen the AstraZeneca vaccine, and it's the vaccine that's mainly going to be distributed and is being distributed in the region that was struggling in other parts of the world. So that's one of the things that we're trying to, we're doing a bit of firefighting vis-a-vis the kind of demand generation activities. So we're looking at a period of pause in vaccine distribution through the COVAX facility over the next months in our region due to vaccine shortages. But in May, we're looking at a big push once again. So I think we will be using this period to, again, make sure that we reiterate on the same messages, improve the understanding of how vaccines work and the different types that are available, et cetera, to be able to push hard starting from May. I hope that answers the question.
Yes, thanks. I'm sure it did. So thank you again, Halim, and congratulations for your great work with IRA. So maybe lastly, can you maybe just share a link to your work, maybe like the IRA's website or something, maybe drop it in the chat so everyone interested can access it.
Yes, with pleasure.
Great, thank you, Halim. So it's my honor to introduce our next speaker. Unfortunately, there was some technical issues and we have to change the order of speakers a little bit. But our next speaker is Dr. Sadomar. Dr. Sadomar is the director of the Yale Institute for Global Health. And professor of Medicine and Epidemiology at Yale University School of Medicine and Public Health. He has conducted studies in multiple countries, including the US, Guatemala, Kenya, Ethiopia, India, Pakistan, and South Africa. His research portfolio includes epidemiology of respiratory viruses like influenza, RSV, and more recently, of course, SARS-CoV-2 or COVID-19, and also clinical trials to estimate efficacy of maternal or infant influenza, measles vaccines, and other trials to evaluate drug regimens to reduce mother-to-child transmission of HIV. He's a very distinguished scholar. He has published over 330 papers in peer-reviewed journals and has mentored over 100 junior faculty and researchers. So without further ado, please, Dr. Saad, take it away.
Hi, it's my pleasure to share some of the work we have been doing in this area. So before I start about building resilience against misinformation, just to remind everyone, and this comes from the WHO framework, that there is vaccine hesitancy is a continuum. It ranges from active demand to active refusal. And there's a whole lot of people, in fact, majority of people are in the middle. So right now we're in a situation where there is active demand in a certain part of the population. The intensity of demand is high. But also, there are a lot of people who are in the wait and see category. And so therefore, they're vulnerable to misinformation and disinformation. Another way of looking at it in terms of vaccination behavior is dictated by, so this is a Russian dolls model that I developed something when I was, did some work with Gavi a few years ago, and then a colleague from UNICEF actually converted it into a Russian dolls version of it, in a sense that underlying a lot of stuff is our values, ideology, identity, etc. On top of that are things like trust, social norms, beliefs, experiences, and fears. And then what we express on top of that are attitudes and then our interaction with cognitive biases, and our thoughts and feelings sort of are at the surface. So vaccine hesitancy is complex. And so this is the vaccine misinformation management field guide that I and others, in collaboration, for example, colleagues from colleagues from UNICEF, First Draft, and PGP had the privilege of developing, and I think the previous speaker briefly mentioned this guide. So I'm going to go through some of the evidence synthesis that we did for this field management guide. After that, I'll present some additional stuff. But overall, just to sort of clarify some of the taxonomy that we are talking about, is that there are different variations of not so accurate information. So there's information itself. It's essentially data with meaning. There are rumors, which is unverified information. It can include stories, reports that spread rapidly through a population. There's misinformation. So there are, technically speaking, accidental falsehoods, or based on things emerging organically based on incomplete information. And then there's disinformation, where there's intentional spread of incorrect information. Often we use, because we don't know the intent, we use misinformation as a catch-all bucket as well. So how to think strategically at the program level, at a sort of a unit level, etc., about misinformation and disinformation is to prepare in advance, build a team, be cognizant of the information ecosystem, and that should be an ongoing analysis. And then build a listening system. It can be now social listening tools are available, are inexpensive now, but there are other tools to keep an eye out for things that are emerging. And countries have invested, especially around COVID-19, in that capacity. And then, a tool like a rumor log, etc., at the community level, for example, can be helpful, especially in certain high-risk communities. Understand, so assess misinformation, do use analyses, etc., and develop actionable insights. So it sounds complex, but there are steps that we provide that can be taken. And then rapid reaction, and then engage in terms of strategic engagement, content development, inoculation content that preempts some of this content, and monitoring evaluation. So these cycles are the ideal cycles. And based on the capacity, things can be prioritized, certainly. But I think this paradigm of prepare, listen, understand, and engage at the strategic level is important and essential and warranted. So there are a few questions that one should consider when thinking about misinformation. Would a response actually just give oxygen to the misinformation, so causing it to spread further? So there is a legitimate concern in certain cases that if your listening is too granular, you may end up providing air or oxygen to some of this stuff. What happens if nothing is done? Are there other facts or events that you should wait for to come out before deciding? What is the reach and scope of misinformation? What is the likelihood of spread or escalation? Could it erode general trust in vaccination or in a specific vaccine, the misinformation or the response for it? So remember, sometimes, just like in viruses, sometimes the virus causes direct harm, and sometimes it's the immune response to it. So what is the capacity to respond, etc. And so when you should respond and whether you should respond is an important strategic decision, and that includes that goes with inoculation as well. So we developed a matrix for this information guide that I said we developed with several partners, and and especially UNICEF First Draft and PGP. So in this guide we provide this matrix that has an indicator and risk. So risk to vaccine hesitancy and demand, reach and scope of misinformation, likelihood of issue spread of escalation, response capacity, general public trust, and response itself, and then risk criteria, and then you can fill out that metrics as a thinking and decision tool at the strategic level. So if you're using it, one example is social listening is not the only way of having your listening phase sort of tools. But if you are using social listening, that this is one interpretation of that matrix in terms of actual decisions. If you find that there are actual information gaps, shape the agenda and have effective content, raise certain credible voices. If there is misinformation, which is low risk, inoculate and pre-bunk and monitor closely. If there is misinformation and that is medium to high risk, debunk with specific myths and so on and so forth. So these are subtle differences between these. So this is an inoculation. So since my charge was inoculation, so a lot of my focus is in terms of pre-bunking. If you decide to do that, it's based on that metrics. It's the fact warning fallacy facts that was referred to earlier that came from this guide, which is, and that we learned a lot from other sort of previous tools, including, some earlier research in climate change communications that some folks did. The idea is to start with the facts, so lead with the facts. So I'll give you an example, a bad example. Sometimes you see the headline, does do COVID-19 vaccines modify your DNA, or is Bill Gates inserting a microchip into your brain or into your body? So don't lead with the myth, lead with the fact, because it has been shown that even if the rest of the piece is debunking it, you end up remembering the myth more than the fact. So start with the fact, lead with the fact, make it clear, relevant, sticky, memorable. Then give a warning when you get to the myth. So misinformation alert, and misleading tactics alert. So say that go after the tactics people are using, especially if it's disinformation. So highlight that in your communication. Then get to the fallacy part. So flag the tactics between use to deceive, undermine trust in disinformation authors if it is true. Sometimes it's misinformation, but if it comes out as disinformation, sort of highlight misleading tactics, reveal hidden agenda, what is out there. Especially this part, the bottom part of this is not relevant to all misinformation, but if it is outright persistent, etc., it is reasonable to highlight misleading tactics and revealing hidden agenda. And then fact, end with fact, start with fact and end with fact, provide alternative correct info, must replace misinformation, cannot leave a vacuum, and make correct information stickier than misinformation in terms of how you communicate it, what information tools that you're using. I'll give you a couple of examples of that, how to make it sticky. So one example is values-based messaging, and some of the work we did focused on that even before the pandemic. So think about the one way of thinking about our values is they're like taste buds. So there are like 5 known tastes, bitter, salty, sweet, umami or savory taste, and sour that triggers our taste buds on our tongue, and the flavor of each food is or a combination of these triggers. And so think about that. And similarly, it is postulated and has been shown that we have a moral matrix. So there are common values all humans seem to have across population, but they're emphasized differently in different populations. So we have these moral taste buds, but just like flavors of food, the combination, the permutation is different based on the stimulus, based on our underlying sensitivity. So the first one is care harm. Universally, we want to protect, we value life, we value protecting others. Fairness, cheating. So the one side of it is positive, the other side is negative. Loyalty and betrayal, authority, subversion, purity and degradation, and liberty, oppression. So these are shared values, but they're emphasized differentially in different populations and in response to different stimuli. So we showed even before this that this was around other vaccines, but even before COVID-19, that vaccine decisions can be values-based decisions, and we showed that emphasis on purity and liberty was associated with more vaccine hesitancy and emphasis on authority. So people who emphasize authority, irrespective of vaccines, were more likely to be accepting of vaccines, and we had lower vaccine hesitancy. We have done additional work on generalized vaccine messaging. So this time we partnered with not just UNICEF, but also with Facebook to develop a general vaccine messaging guide that goes into what is sticky information, etc., and that kind of stuff, and how to communicate effectively. Then broadly, I have the privilege of being part of the WHO Technical Advisory Group for behavioral insights and sciences in health. This is a new group that Dr. Tedros established based on some advocacy around this, that WHO should have a behavioral orientation. And one of the first tasks that was given to us to create a guide or a sort of a summary of potential interventions countries can take. And the first one is to create an enabling environment. So this goes beyond misinformation, but a lot of misinformation, and the way to counter it requires a broader response. So the first is to create an enabling environment, making vaccination easy, quick, and affordable in all relevant aspects. So a lot of behavioral interventions are not just interventions that work through communication. They're also how the choice architecture is developed and deployed. Harness social influences. So if you're emphasizing social norm, even if it's emerging social norm, even if it's in a subgroup like healthcare workers, that is important. And then increase motivation through open and transparent dialogue including around safety and benefits of vaccination. So some of the last one was covered earlier as well, but this guide goes well beyond misinformation and helps you. I just wanted to highlight that at the end to say that you need to countries and programs need to focus on a strong comprehensive program. So I'll stop here in the interest of time. I was keeping an eye out for how this was going, so I wanted to keep some questions at the end. So I'm finishing within the 15 minutes. Or actually, I think exactly around 15 minutes.
Okay, thank you very much, Dr. Omar, for a fascinating presentation. Thanks a lot. We have actually just one leftover question that I'd like to start with in the Q&A. We'll take 5 minutes before our colleague from Pakistan join us. So the question by Islam Saeed: what is the reason behind high level of vaccine hesitancy? If you share your insight, Dr. Omar.
Yeah, that depends. First of all, it is not a given that by the time a lot of a lot of countries deploy the vaccine, that the vaccine hesitancy will remain high. In places where vaccine has been deployed, early vaccine production countries, vaccine hesitancy has declined as the program is rolled out. And even now there is variability in that. And we have a sort of a paper coming out that there is variability. Having said that, there is still, in order to reach herd immunity, you need to have high vaccination rates. So there are a few reasons. One is the underlying sort of concerns about vaccines and a few folks who don't particularly like vaccines, but that's a very small group, not more than 5% in most places and even lower. A bigger chunk around COVID-19 is because these are new vaccines. And a lot of people are fence sitters and not outright vaccine opponents and are persuadables. And the third thing is that a lot of the fence sitters are influenced by emerging misinformation and disinformation, and sometimes the real uncertainty around vaccines. So some, for example, adverse events take time to resolve in terms of developing a scientific assessment of them, looking at the data, interpreting those data. In that period, unfortunately, a lot of concerns take hold, even if there is at the end, the data is supportive of the benefit of vaccination versus the risk of that specific vaccine product.
Okay, thank you. We have a question from Dr. Najwa Jarour from Jordan. So the question: how we encourage applying misinformation risk evaluation matrix on the ground?
So we do provide some examples in the guide, the field guide of how to apply that, and one way is to use the social listening tools, and we say that how do you do that using different sources of data? So sorry. So I think that's without, in the interest of time, I don't want to go through a specific example of what piece of information comes in there, but we do provide a lot of detail and sufficient examples of how to take a piece of information and say, look, whether it is high, medium, low risk, what is the indicator in terms of its ability to spread, influence, actual vaccine decision, and so on and so forth, and the ability to respond. And so that helps you decide that, and I would refer you to the misinformation field guide.
Okay, thank you, Dr. Saad. Actually, there is a question that's not specific to your presentation, but I think it's really quite important to handle. And that's, it says, in war zone areas, how does Infodemic engage people? Because it's really part of the Infodemic management is to engage people. And that's specific to war zone areas. Thank you.
No, that's a really good question. And that's the toughest part. The key is to figure out, and it's easier said than done, what are the information pathways? So these are disrupted communities, but they are hungry for information. They do get information. So there is work based on work in displaced populations in conflict zones. They do seek out information, and the general channels, sometimes it's old school information seeking through person-to-person communication. Often it is increasingly, even in sort of displaced populations and in conflict zones, is through channels like WhatsApp, etc. So figure out what is the mode of communication for all sorts of other information, and that is likely to be the channel that they are using for vaccine-specific information, etc. And the other insight is that because of other things going around, the consistency of ability to access information goes up and down. So it's something to consider around that as well, that what are the more consistent channels versus the more disruptible channels.
Okay, thanks a lot, Dr. Omar. So actually, I'll take the opportunity. I think we have one or 2 minutes, and I'll take the opportunity to ask to ask you a question myself, since you're a member of the TAG Behavioral Insight Group. And my question is really with regard, again, to the issue of the engaging and empowering people and communities, listening to them. So we have seen the research agenda that came from WHO with regard to the issue of the infodemic. Yet again, do you think that we are, I mean, especially in our part of the world, do you think that we have enough behavioral scientists that can help us? Because, I mean, most of the WHO work is really coming with medical background, and here we are with really very much social issue. And even the research agenda, if you look at, is really, again, it's behavior sociology. So what's your insights toward this issue? Thank you.
Yeah, so I was among the advocates that publicly advocated for WHO's orientation, and that this tag is one part of WHO's reorientation around behavioral insight. And I strongly believe that the next public health emergency, or even this one, would require certain set of basic competencies, just like you have a basic competency to interpret an odds ratio. That every a lot of people would require if you're working in public health, etc. Certain behavioral insights-based competency has to be part of those core skill sets, and that's part of it. That yes, have the engagement of specialized social and behavioral scientists, but also have a vocabulary, a set of competencies, a set of skills that you can disseminate across the board, that countries and programs can deploy more broadly, and that becomes part of the basic skill set.
Thank you so much, Dr. Omar, for, again, a very interesting presentation, and for all insights we heard from you. So thanks a lot, and you will be with us until the end. We might have more questions at the end. So hopefully our colleague from Pakistan is with us. I hope so. There was a connectivity issue, and we're sorry about this. So Dr. Nayaz Muhammad, are you with us?
Nayaz Muhammad. Dr. Nayaz Muhammad is in a meeting with the Minister of Health. I am Dr. Ikramullah Khan, and I am the Director of Public Health and Director WEBi Khyber Pakhtunkhwa.
Okay, so
and I'm also here. I'm Dr. Durdana Poonam.
Okay, so good
Thank
afternoon, good day, and welcome to this webinar. I'm sorry I don't have the complete biography of yourself to introduce, but I do welcome you to this webinar, and we are looking forward actually to hearing the experience from Pakistan, the country experience from Pakistan. Supposedly you will be really bringing your country infodemic experience in responding to the COVID-19 infodemic. So we look forward to hearing from you. We're supposed to have 15 minutes for your presentation, whether it's one person or a shared presentation. And again, we welcome and we look forward to your presentation. Thank you.
Thank you, Professor. And I am from Khyber Pakhtunkhwa. Pakistan has 6 federating units, and Khyber Pakhtunkhwa is one of them, previously called the Northwest Frontier Region. In Khyber Pakhtunkhwa, like all the country, when we received the information that there are a number of cases of pneumonia in China, Wuhan, in the end of December, the health system was sensitized here. And then we had the first meeting of our public health committee, public health committee meeting on 6th of February. Before that, COVID-19 was declared as a public health emergency by WHO, and we started our activities. The first line of action was to have that thing at the airports and the border crossing points. We started screening over there, and then the process started. And to respond effectively, we developed a provincial action plan for detection and response, then for the lab testing, the testing strategy, and then ultimately the clinical case care, case management guidelines. So the whole pandemic was according to that action plan. The response was based on that action plan, and the SOPs were followed true in spirit. The heading of this slide is 1700. This is a universal access number for the Khyber Pakhtunkhwa, which gives us whole of the information of Corona. It have different extensions. We give information and response for testing, for lab services, and then we have also the information sharing at this number. And another thing, because when a huge number of people were affected by the Corona, so the people were depressed, and then we started a service of mental health and psychosocial services, which is also given by this 1700. So it is the lifeline or the call center which did everything for us in this pandemic. This slide I already mentioned, and about the National Action Plan. By acting or by following this action plan, we were able to reduce our morbidity, mortality, and the case spread. If I discuss the national numbers, Pakistan till this point, we have about 663 positive cases, right from the start of this pandemic, out of which the share of Khyber Pakhtunkhwa is 87,000. And in total, the number of deaths is 14,300 throughout the country, in which the share of Khyber Pakhtunkhwa is about 2,342. Initially, when the pandemic started, we started our testing, and we used to take the samples and we send it to Islamabad, the National Institute of Health. We didn't have any laboratory here in Khyber Pakhtunkhwa, but during the course of the time, we developed 13 public health reference labs, in which whole of the COVID tests are conducted. Till date, we have conducted about 1.4 million tests for the COVID suspects, and out of that, 87,000 were positive.
I am
keeping
very,
in view the high number of collaborated with the partners,
doctor,
in which the partners were.
I'm
Yes.
terribly sorry for the interruption, but are you supposed to share your slides with us or not? It's really for you to decide. If you'd like to share your screen, because we're not.
The screen is shared.
We're not seeing your screen, so please make sure that you share it with us.
No, we have sent the presentation with you, and right now at this time, we don't have the right to share that presentation. We tried to share this presentation, the screen with you, but the system is not allowing us.
Yes.
Okay, thank you. So I'm not sure if the GHD people can help the organizer. Anyway, I'm terribly sorry again for interruption, and we
no problem, no problem. We tried to share it, but it's not happening. So we started the presentation from our screen.
We can share it from our side. It's not a problem.
Okay, thank you so much. Thank you so much. So please go on.
Should I continue?
Yes, please. We have.
Yes.
Okay, we have now the slides. So please go on. Thank you.
Yes. So the Department of Health, they developed a core group for this response activities, and different sections were developed in that core team, which was looking after the detection and response, the coordination with the line department, then with the hospitals for case management, and then later in this last few months, we developed another section which deals with the COVID vaccines. So the department was actively involved in that. We also involved the partners with us. And then the partners like WHO, UNICEF, JSI, GIZ, and many more. We also had coordination with the different line departments, the line forcing agencies, the local government, the police, nutrition, and other, yes. So I think the screen has been shared, and this is the third slide which I am presenting. Can you see these slides?
Yes, thank you so much.
So during the pandemic, a lot of information was passing through on different channels. Some information helped us in convincing the people for giving their samples, bringing their morbid patients to the hospital for proper treatment. But this information also had a drawback or a misleading effect. The information on the social media, on the internet, it developed a propaganda in which the people were not believing this thing that corona is a disease. They thought that it was a drama or from some vested interest in it. So we had to deal with it, and we developed our communication team, which started developing that plan, and the plan was developed. And then we bombarded the social media, the internet, the TV channels, the newspapers, even announcements, our senior officials, our celebrities, and those who are the opinion maker. They were visiting the fields, the hospitals, and the areas of lockdowns. So to give the people this thing that the disease is real and it is affecting a lot of people, and the high risk groups, they were shown to them that these are the high risk group people who can be affected from this disease. And this information resulted in confusion and risk-taking behaviors and led to the mistrust in the health authorities. But our successful communication plan and the execution of those activities cleared the situation. And these are some of the, yes. Then we developed some video testimonials, and as I mentioned that we engaged different forums, political forums, the professional forums of the doctor, nurses, paramedics. We engaged our partners, and we used all the available resources in terms of print and electronic media, and we used those forums and spread our message regarding the disease. And Alhamdulillah, we were successful in it. Now the people are cooperating with us in implementation or observing the SOPs. The hospital care has improved. These are some of the initiatives like we have some festivals in Ramzan and in the Eid days. We started our sampling from the markets. In the Eid al-Adha days, the cattle mandis were there. We started our sampling there in the cattle mandis, or those places in which there was gathering of people. So we did all these things. Some of the area of Pakistan which is well known for the tourist activities, that is Swat, Abbottabad, Mansehra and few other districts. And the season of the tourism has started just now. So we have started our sampling over there. The tourists are being sampled there. The hoteling industry, all the workers are there, they are being sampled. So we are looking at the every aspect of our system, that where we expect that there will be a gathering of people, or the people will be mixing. So we do sample them, we test them, and then take accordingly the NPIs. We call it the non-pharmaceutical interventions, like the smart lockdowns, the fines for not observing the SOPs. Then we have closed the schools in about 17 of the districts now recently, because the school positivity has increased from 2-3% to 6%. And then we have sentinel sampling as well. Like we are following a multi-pronged strategy, that we are almost covering every place where from where we can get the samples, and from where we can get a picture that the disease is spreading. So we coordinate with the district administration, and we implement our lockdowns, smart lockdowns and broader lockdowns. Then when the vaccine was registered and the trials were completed, Pakistan took support of China, and we were given the Sinopharm vaccines. And initially it was for the healthcare workers, and in the healthcare workers, it was the frontline healthcare workers, those workers who are working in the ICUs, the high dependency units, the isolations and quarantines, and the number of those health workers was 28,000. So Alhamdulillah, in the first phase, we vaccinated the healthcare workers. Then we started their second dose. And from 10th of March, we started the vaccination for the higher age groups. We are now vaccinating 60 and above group. And now in Pakistan, we have Sinopharm vaccine. And tomorrow we'll be getting the CanSino vaccine, which is for the 80 plus, and it is single shot vaccine. So we'll be getting it tomorrow, inshallah, and we'll be implementing it in our COVID vaccination centers. For the vaccination, we have established 280 CVCs, COVID vaccination centers, and we plan to increase the number by 500 in the next month, and up to 1,000 by June 30th. So we want to vaccinate the higher age groups, and then we'll be going in the descending order for the lower age groups. These are some of the information which we are giving in our own local languages for the people. The 1166 is another universal access number in which a person can register himself for the vaccination. He's registered, and then a code comes with the name of the health facility, the date of vaccination, and the person goes to that CVC and he is vaccinated over there. And the system has been developed like this, that it can produce the e-vaccination certificate. If we need a certificate for vaccination, COVID vaccination, that is electronically generated from this system. These are the numbers of health facilities. And apart from targeting the densely populated cities, we have also targeted the areas which are hard to reach for the people. So we have established a huge number of health facilities over there, and we are planning to extend it in the future, inshallah. This is the vaccination activities and the screening activities. This was all about from Khyber Pakhtunkhwa. Thank you very much, and we can entertain questions as well. Yes.
Great. Thank you for your great presentation, and thank you for stepping in for Dr. Mohammed. I understand he's busy right now, but your presentation was great. Thank you. So maybe we can ask you one question before moving to the panelist discussion, opening it up for all the different panelists. So maybe I have a question to ask you specifically. So we have a question from the audience. Do you think that COVID-19 vaccination will support the polio eradication or will it disturb polio eradication? So I think the question is asking like, how is the COVID-19 vaccination campaign or the role of COVID-19 vaccines will affect polio eradication activities?
May I comment?
Yes, please. Yeah, this question
Yes.
is for you. Yes.
Yes, this is for me. So the polio campaign started yesterday from 29th in the province of Khyber Pakhtunkhwa. And during this campaign, we'll be vaccinating about 6.4 million children. This is the whole, the under 5 population of Khyber Pakhtunkhwa along the newly merged districts, which were previously called as FATA. So the yesterday we achieved 7,000 vaccination, COVID vaccination, and we vaccinated about 1.3 million children under 5 for the polio. So it is not affecting, and we have asked our district teams, we have 35 districts in our province, and we have asked them to have focus on both the vaccination. Polio is our big problem, but now COVID is an epidemic, so we need to vaccinate our most vulnerable age groups for the vaccination. So they are going side by side, and Alhamdulillah, till this time, we don't see any effect of these vaccine on each other, these campaigns on each other. Yesterday I told we hit our all-time best 7,000 vaccination per day in Khyber Pakhtunkhwa. Normally our rate was about 4,000, 5,000, 5,500. So yesterday we were able to achieve 7,165 vaccinations. So I think it won't affect each other. Both the campaigns, I think they are augmenting each other because the health worker are going to the every household in the province, and they are giving the message of vaccination for COVID. They are asking the households to get registered, your 60 years and above elders, and the code will be issued and they'll be get vaccinated in the nearest CVCs.
Great. It's great to hear that they're augmenting each other. So a related question for you. How do you see synergies between demand creation for COVID-19 vaccine and the demand for polio vaccine in Khyber Pakhtunkhwa?
First, I'll mention the COVID-19 vaccine. Initially, we started our vaccination for the healthcare workers, and the pace of the vaccination was very slow. People were reluctant. They were not refusal, but they were reluctant, and they were observing other people to get vaccinated, and if there is any AE5 or the side effect of vaccine. But Alhamdulillah, till that time, this time we don't have any major AEFI. Only 18 AEFIs were reported, and they were minor ones with the mild fever and the pain at the injection site. So that encouraged the people, and the number of people coming to the CVCs, the healthcare workers and the senior citizens. The number is increasing day by day, Alhamdulillah. And the same is for the polio vaccine. A lot of propagandas are also associated with them, and we had a huge number of refusals 4 or 5 years back. But the number of those refusals is coming down with every campaign. And I can give you an example that in April 2019, in a UC near Peshawar, Mashokhail, and there was suddenly a propaganda was started that propaganda was started that we had a vaccination campaign for up to age of 10 years for polio vaccine, and they developed some serious EFIs. This was the information given by different news channels and the social media, and a lot of people were visiting our hospitals. So the district polio control room at Peshawar immediately responded. We visited this place over there. Then we visited all the hospitals, and we engaged ourselves with the community elders of that UC and the surrounding areas, because this affected the adjoining district as well as the whole country was affected. And on that first day, we had 500,000 refusals in Khyber Pakhtunkhwa. So the PI team then engaged with the local community. The communication plans were developed. The minister and the secretary, they came on TV and they gave their rebuttal on that. And with the passage of 2 or 3 months, we were back on track. So such kind of information, the negative information, it affects the campaign, it reduces the demand, it creates the refusals. So your communication strategy and your ground force should be equally up to it to deal such kind of infodemics. But Alhamdulillah, we did it and we are doing it. And it was a very good example for us, and it motivated our health workers that after such a disaster, we started that polio campaigns back in, probably we started our next campaign in June 2019.
Great, thank you for your very thorough answer. So maybe in the interest of time, maybe we can move on to the Q&A session. So Professor Hayam, maybe you would like to start with a question for Dr. Saad.
Okay, thank you very much, Atsu, and many thanks to our Pakistani colleague. Congratulations on a very good presentation and work.
Professor,
there is a question to Dr. Omar, but before that, may I kindly ask you, just before you leave, a question about the mental health services that you said you have done in Pakistan as part of the response. Welcome, Dr. Nayaz. Welcome again, Dr. Nayaz, to this webinar. And many thanks to you and your colleagues. So the point of mental health, because we know that this infodemic and this amount of information, have you had any indication that the infodemic have affected the mental health of the people there? Do you like to respond, Dr. Nayaz? You are muted.
Yes. Hello, everyone. Can you hear me, madam?
Yes.
I'm sorry, first of all, that I was unable to join it at proper time. My expert director, EPI, and director public health, and he is the eminent epidemiologist of Khyber Pakhtunkhwa, is a province in the north of Pakistan. He has also presented. I'm sorry that I got late. He has explained everything here in Pakistan, in KP, what we are doing regarding the COVID response from the day one for the last 1 year. And again, the vaccination mechanism, we have started when the vaccination, and what were our criteria, what was strategy, and how we are rolling out it in the province for general community. We will be almost till now, we have done more than 80,000 people vaccinated for the first dose, and also the due second dose has been given. In this 40,000 is frontline healthcare worker. We started with frontline healthcare worker from 3rd of February. the frontline healthcare worker were duly described by our National Command and Control Center, which is controlling the all COVID response from day one for the last February 2020. The worker working in the ICU, HDU, isolation, triage, at the same time worker of the emergency department, and we had RRT teams, the Rapid Response Team 1 and Rapid Response Team 2, they were included in the frontline worker. They were properly registered with our Command and Control Center, and we developed an NIMS for that, and also a logistic MIS for the vaccine distribution. Initially, we started.
Dr. Nayaz, just for the sake of time, the question was regard to the mental health, and has been any indication from your clinic mental health services that the mental health was affected by the infodemic and the misinformation in the country? Is there any indication like this?
Yes, Professor, actually, here in Khyber Pakhtunkhwa and Peshawar, we were having a mental health support program already working since 2017. Although our normal health system is not addressing it properly, but there was an incidence of Army Public School in 2016, and post that scenario, there was a terrorist attack on a school, and then the UNICEF supported the health department Khyber Pakhtunkhwa for establishing a mental health support center with a helpline and clinical psychologist across the Peshawar. When the COVID emerged in the last year, then we requested UNICEF to support us in the post-COVID scenario and the mental health issues which the families and children and women of the COVID sufferer or otherwise as a whole, because it was initially a very big misunderstanding among the people and fear. And you see, when the patient got admitted, culturally he was isolated from his family members, and then if somebody died, nobody can attend the funeral ceremony. So these are multiple factors. At the same time, there was also lockdown, economic activity was closed. There was also economical constraint, the people, which resulted in the mental health issues. So that program, we expanded it to all division territories of the KP, and now it is working with a team of clinical psychologists across the province. They are doing, number one, clinical services at our secondary level hospital. They are doing outreach activities for the community awareness as well as the clinical support. At the same time, they are also clinically training and capacity building of our own healthcare provider at the facility level and LHWs at the community level. So now they are in a multi-sectorial approach.
Thank you so much. Thank you so much, Dr. Nayaz, to yourself and to the team, and thanks for sharing with us your Pakistani experience. That was very good, and congratulations. Just we have actually less than about 6 minutes, and we have again more questions to Dr. Omar, and if I may take with kindly a short answer from you, Dr. Omar. The question is, do you think framing this intervention using the top-down medical metaphor of infodemic and inoculating against information could have negative effects on engagement with fact-based tool counters, especially in the post-trust context?
Sorry, I couldn't hear the last part of you. In what context?
Post-trust context.
In post-trust context?
Yes.
Yeah. So yes, I think we have limited options to deploy things quickly during a pandemic. So unfortunately, we don't have the luxury of mass community engagement on the ground. There is some effort happening, but not at the magnitude which is required. So it's a global pandemic. And the reality is that things need to be scaled up quickly, things need to be responded to quickly. So therefore, new and old media sources are taking the precedence over some of the more community engaged, direct community engaged solutions. But having said that, this needs to be followed by and enhanced by as much efforts as possible in the area of direct community engagement that go beyond the mass and social media and mass social mobilization. And so therefore, I think given the choices, the limited choices that are out there to address some of these things in an ongoing basis, in a rolling basis, we have to do, countries have to do what they have to do, but then it needs to be followed by, in a long-term basis, to ensure that the trust is maintained between communities and programs, between communities and the overall vaccine enterprise.
Okay, thank you very much, Dr. Saad. I don't think that we have time to any more question. Maybe Atsu, would you like really to wrap at the end? And before giving you the opportunity, I would like myself to thank the presenter for a very, very good presentation, and of course thank the organizer and all the attendees for participating. And maybe I ask you, Atsu, for wrapping up. Thank you.
Thank you, Professor Hayam. And I'd like to echo what you just said. I'd like to thank GHD for organizing this webinar, and all of the panelists for taking the time to present their work. And of course, all of the participants for attending the webinar. I think maybe to wrap up, I think the three presentations really illustrated the multifaceted nature of infodemics, the different typologies of information like misinformation, actors creating disinformation, and also having to think about behavioral factors and how they have been impacted by history of past vaccine events like polio misinformation in the case of Pakistan. And also like, because of this complex nature of infodemics, I think the webinar also taught us that infodemic management also has to be a whole of society approach. As Halim outlined in his presentation, infodemic management needs to involve not only research, but also advocacy, coordination, country support, and maybe even including coordination within country with different departments, like not just the Minister of Health, but in Pakistan, you worked with Department of Tourism to reach out to tourists, to communicate health information to tourists. So I think that kind of a whole of government, whole of society approach is really needed to address the COVID-19 infodemic. So that was my takeaway from the three great presentations today. And again, I would like to thank all of the participants and the panelists. Thank you.
Okay, thank you so much, Atsu. And again, thank you all presenter, attendees, and of course, organizer, GHD team for organizing this webinar. Okay, so all the best to you all.
Thank you, Professor Bashir, and all of the organizers.